Hi, thank you for joining us. This webinar will begin shortly. Good morning, everyone, and welcome to today's webinar hosted by PYA. Today, we're continuing our timely, tough, or tricky physician compensation and fair market value topic series with a presentation on traversing tricky situations in common call coverage scenarios. PYA is happy to present today's webinar on this important topic. You'll have the opportunities to submit questions to today's presenters by typing a message into the questions pane of the control panel. We'll collect these and address them via email after the webinar, and all our webinars are recorded and released with a copy of the slides after the event. With that, I'd like to introduce Lyle Oelrich, Principal, and Zach Doolin, Senior Manager at PYA.
Thank you, Shannon, and good morning to all of our participants. My name is Lyle Oelrich, and I'd like to welcome you all to another timely, tough, or tricky webinar. As a part of this series on key topics in physician compensation and fair market value in 2023. Today, we're going to be talking about a topic PYA gets a lot of questions about on a regular basis, that of call coverage. And while on the surface, certain call coverage scenarios can appear commonplace, there can be some tricky situations that our clients find themselves in. So as we progress today in our presentation, we will be talking about several of these scenarios. But before we begin, I want to take care of just a few introductory items. First, as a quick reminder, the discussion today will focus on general educational topics only, and nothing we talk about here is intended to issue an opinion, which would be based off of a specific set of facts and circumstances. And on top of that, given our limited time today, there's no way that we can cover all the applicable scenarios and factors that need to be discussed. So please forgive us if there's a specific scenario you might be dealing with that we did not have time to address today. But we're always happy to talk with you all about these scenarios, so please don't hesitate to reach out to us. Second, we'll be asking for your participation during our discussion today by answering a couple of quick multiple choice questions, and you'll need your phone to do that. So if you'll grab it and have it handy, I'll share more information on this in just a couple of moments. To talk about this subject today, I am super excited to be joined by my colleague, Zach Doolin. Zach's a senior manager in our compensation valuation, planning, and design department. He's located in our Knoxville office and has over 10 years of experience. Zach has worked to design physician compensation for and render fair market value opinions on hundreds of different call coverage scenarios in practically all specialties. In turn, I'm a principal in PYA's CVPD department. Like Zach, I'm located in our Knoxville office. I have over 25 years of experience and regularly speak and write on a variety of physician, financial, and operational and strategic issues, such as compensation valuation and commercial reasonableness related to call coverage. As we start today, as we've done in other webinars, I wanted to share the results of a poll that was taken in January of this year that we're using to organize this series throughout 2023. And as you can see here, we surveyed 50 experts about physician compensation and fair market value topics that they're currently facing, and you'll see the top 10 list here as well. I won't go through all of these. You certainly can read them. Just a couple of quick notes. Of course, APPs landed at 1 and 4. We'll be having a webinar coming up on that likely next month. if not the month after, so be on the lookout for that announcement. We've previously spoken about the end of the public health emergency, as well as the 2023 Medicare Physician Fee Schedule and anesthesia and other hospital-based specialty financial arrangements. So to the extent that you have interest in those, as well as there's a full 2022 Triple T webinar series, please feel free to visit our website, and I'll ask the moderator to chat in a link to that website, so it'll make it easy for you to be able to find that information at this time. So let's jump right in. As I mentioned, today we will discuss some of the challenges our clients face when contemplating some fairly common call coverage scenarios, such as with employed physicians, independent contractor physicians, where market shortages exist, when APPs assist physicians with call coverage and concurrent call coverage. And for those of you who may not be immediately familiar with the term concurrent call coverage, that refers to when a physician provides call coverage to 2 or more hospitals or specialties on the same day. And certainly more on that here in just a few moments. Now, as we jump into these topics, we've organized our thoughts by addressing some of the most frequent questions our clients ask us when confronted with making decisions in each of these scenarios. So as you'll see here, in the first potentially tricky situation, and we hear this likely most often from our clients, a client has benchmark data, but they want to know how to determine what they should pay their employed physician. And this really is important because benchmark data in and by itself is not fair market value. It provides a range potentially of compensation to be paid in specific scenarios, but benchmark data in and by itself is not fair market value. So when you find yourself in this situation, the first thing you want to do is to identify all the relevant facts and circumstances around the arrangement, such as key drivers of call coverage, with, from my perspective, a particular emphasis on physician availability, call burden and frequency, and the likelihood of the physician receiving any form of payment, such as collections or work RVUs, besides what is often a per diem payment, but certainly could be other forms of payment, such as an activation fee. So let's talk about physician availability for just a moment. This can refer to many, many things, but it may be the number of hours of coverage. So is the call coverage from 7 p.m. to 7 a.m., or is it literally 24 hours a day? Can the physician see patients while on call, or does the call interrupt daily operations so frequently that they can't see patients? Is the call restricted? Is it unrestricted? And could also consider how many physicians are in the call panel. So by way of example, there may be 2 physicians, and of course that means that a physician is on call every other day. Now, regarding call burden and the likelihood of payment, we're fortunate to have some OIG guidance that we can consider. And while the OIG advisory opinions are only specific to the very situations that they're talking about, they do provide some context for what factors the government believes are relevant to examine. And so, for example, and probably 2 of the more prominent advisory opinions on call coverage are advisory opinions 0905 and 07-10. And if you're ever dealing with a call coverage situation, I'd recommend you have those handy, perhaps read them and reflect on them. But some of the key items coming from these advisory opinions include the likelihood of receiving payment while providing call coverage. So in other words, what's the payer mix? And is there a lot of self-pay and or Medicaid? And if so, is it likely the physician may be providing services, meaning call coverage services, with little to no collections without any form of a payment, such as a per diem or an activation fee or another structure? Another coming from these advisory opinions is patient acuity. sort of the severity of illness and maybe the degree of care required. For example, is this a trauma center or is it a non-trauma center? The third that I like to mention related to this advisory opinion is the likelihood of being called in. And I think this is probably one of the more prominent points that people really need to think through. But for example, how many phone calls are received while the physician's on call? How many ED visits does the physician make? How many inpatient consults are performed? And how many surgeries were performed while on call? All of that really has to do with the burden as well as certainly the likelihood of being called in. And the fourth that I want to mention, and there are others as well, but in our brief time together, is making sure the compensation is for identifiable services. Now, in certain instances, you may be paying for availability, but when you do so, there should be with some regularity an event the physician responds to, such as the taking of a phone call or being activated to come to the hospital, and so on. Now, after we've considered the OIG guidance, next we want to understand how the call coverage payment will work within the overall terms of the medical staff bylaws and the employment agreement. So in this case, you may find yourself asking questions such as, by origin, do your bylaws allow you to pay for call? Some may not. Is the physician over the retirement age of being required to take call according to the medical staff bylaws? Does the existing employment agreement contemplate the provision for call coverage in a physician's base compensation? Is call paid every day or only a certain amount of days after a monthly or perhaps annual gratis threshold is met? All of those are really important aspects to contemplating how the payment will be structured and when it's actually paid. And then finally, you'll want to document your rationale, and certainly you want to document the key facts and circumstances. And sometimes, these things like the burden, the number of ED visits, those things may not be immediately available or tracked, and you may need to interview a physician for some of those statistics. But those are all key facts and circumstances you'll want to document. You want to make sure that you document any benchmark data that you considered. You may also want to document the local market data that you've relied upon. And when you do that, don't forget to scrutinize these items. Are they truly being paid in the local market, or is it just hearsay, perhaps? And when the rates are truly being paid in the local market, is it apples to apples to your situation, or do you need to make some adjustments for your facility? As a quick example, maybe there's a different payer mix where the physicians will receive a lot more in collections than the other facility, and perhaps that's your facility. And then finally, to the extent that you're doing a more formal analysis, such as a valuation analysis, you want to make sure that you document the valuation approaches that you relied upon. And Zach, I think, is going to talk a little bit more about these later, so I won't get into that here as we talk at this point. And of course, you want to document your conclusion once you have all those items compiled. So as we transition to talk about independent contractor call coverage, let's pause for a poll that I think will help drive that discussion a little bit. So if you all will take out your cameras and hover over the QVC code, some may call it a QR code, and follow a link to this poll. So here you'll see, do you pay a different rate to your employed physicians versus independent contractor physicians participating in the same call panel? So as some of the results come in here, I will just quickly say that from my perspective, the answer may be, it depends. And I can make a case, facts and circumstances, to pay the same rate or to pay a different rate. I think generally speaking, most people typically pay a different rate. And I think that's kind of what we're seeing as some of these poll results come in. The majority pay a different rate, but there are some that don't. But again, Zach's going to delve into this here in just a moment. So perhaps as you're answering this poll, you can be thinking about what he's talking about and kind of benchmarking it to how you approach it. So that being said, I'm going to pass the slides over to Zach and let him take us from here.
Thank you, Lyle. Well, that was certainly an interesting poll. And I would agree, I think the answer is it depends. But this is a question we get asked a lot by our clients. Can I pay an independent contractor the same amount as an employed physician? Or what about equal to my locum tenens rate? Let's start by diving into the first part of that question. Can I pay an independent contractor the same as an employed physician? Well, as Lyle mentioned, anytime you're looking at call coverage, it's important to consider the three drivers of call coverage. In this case, availability to start. Both providers, an independent contractor and an employed physician, are both available 24 hours, so there's no difference there. So then the burden. Well, the burden of the call panel is also the same. Both providers will respond. They'll have the same likelihood of responding the same number of times to phone calls, surgeries, visits. But the difference with an independent contractor and an employed physician often is in the third driver of call coverage. What's the likelihood of receiving additional payment? Well, in this case, an independent contractor is also able to bill and collect for their services. So it's important to understand what's the payer mix, what's the likelihood of them actually receiving collections for performing services. And on the other hand, the employed physician may also receive additional payments such as work RVU, incentive bonuses. Oftentimes employment contracts that are based on work RVUs have some sort of work RVU conversion factor or bonus amount that for every work RVU generated in addition to a threshold, there's some additional payment. The work RVUs generated from call coverage services counts towards that bonus. So at the end of the day, thinking of the three drivers, when you're determining whether or not you could pay the same amount, it's important to go back to those three drivers and think about the total payment compared to the total burden, compared to the availability. If the amounts are equal to each other, yes, you could pay the same payment. If the amounts appear to be different or are different, then you should consider paying a different amount. The next part of this question was related to locum tenens, and this is one we get a lot. Well, as long as I pay something less than a locum tenens rate, that's fair market value, right? Well, maybe, maybe not. Most of the time, not. And let me explain why. I think it's easier if we start by looking at an example. So in this example, we pulled call coverage survey benchmarks from 3 different surveys specific to the specialty of orthopedic surgery. These results range from as low as $363 to as high as almost $2,000. And then there's a little blue or teal colored line at the very top of this figure for a locum tenens rate. This locum tenens rate is one that we saw in a contract recently, and it was an easy one to pull in for an example, but almost $3,000 a day. So why is the locum tenens rate $3,000 a day, but all of the benchmark data we have only going up to $2,000? Well, it has to do with the way locum tenens contracts work. The locum tenens company will start by negotiating with the physician. So the physician and the locum tenens company come up with a rate. Let's say, for example purposes, the physician agrees to provide locum tenens services for $2,400 a day. The locum tenens company then goes out and negotiates a rate with the hospital that includes a profit margin and some overhead costs for the locum tenens company so they can pay their bills as well. So the ultimate rate that gets charged to the hospital in this case is almost $3,000, but the amount the physician's bringing home is only $2,400. Well, why would the $2,400 be higher than the $2,000 in the 90th percentile? Well, it also has to do with the way the collections work. So in locum tenens arrangements, the hospital maintains the right to bill and collect for services, whereas in a traditional independent contractor arrangement, the independent contractor would also have the right to bill and collect in addition for the services. So that additional $400 could be the additional compensation making up for the part where the physician's not also able to bill and collect for services compared to call coverage per diems. So again, it comes back to the three drivers of call coverage. And in this case, the third driver, what's the likelihood of receiving additional payment? So the difference in locum tenens rates oftentimes has to do with the ability to bill and collect, but also you're not always dealing with the physician, you're dealing with a company that also has a profit margin built in. So in most cases, it's not appropriate to pay a rate equal to the locum tenens to your independent contractor. The next example has to do with market shortages. And as Lyle mentioned at the beginning, there's lots of different scenarios we could present related to what are you doing? There's a shortage in the market. One of the questions we get asked a lot has to do with, my market has a small number of specialists available to provide call coverage. As a result, call coverage benchmarks don't always align with market expectations. And what that means is you're trying to negotiate a rate for a specialist in your local market, but the specialist is requesting rates higher than what your benchmarks are suggesting is reasonable. So what do you do in those scenarios? How do you justify paying a rate that's above the 90th percentile for benchmarks? What do you do? What alternatives do you have? Are there other ways to consider whether a call coverage payment is reasonable? Well, the first thing we recommend to our clients is to make sure you're looking at the right benchmarks. On the prior slide, we presented 3 different survey results. Well, each of those surveys has numerous different ways to present call coverage data hourly. Some of it's restricted, unrestricted, trauma, non-trauma. Some of the data points are combined that need to be filtered out. So making sure first you have the right underlying level of benchmarks, and then making sure your benchmarks align with your specialty. One specialty that I'm currently working on for a client has to do with interventional neurology. There's not a benchmark in call coverage for interventional neurology, but knowing interventional neurology is made up of neurosurgery, neurology, and radiology, the combination of 3 specialties, that gives us a starting point for purposes of understanding whether a rate's reasonable. It's not as complex as neurosurgery. There's not brain surgery involved. There's not a spine surgery involved. It's more complex than regular neurology, and it's more procedural than general radiology. So in this instance, we would recommend probably a combination of different benchmarks to see if you're within a realm of reasonable benchmark expectations. But let's say that you're moving on from there and you're looking for other alternatives to determine outside of benchmarks. How do you determine if call coverage is reasonable? Well, we go back to the market and the cost approach of the valuation. The market approach is what is the local market price for a particular service. If you're buying a car, you could go to multiple dealerships and look at the price for that same car to determine what the local market price is. In this case, dealing with call coverage, maybe you could perhaps survey other local hospitals as to what they're paying for a particular call coverage specialty. In some instances, there's specific local market surveys available for purchase. Another way would be to survey the physicians in a particular market as to what they would be willing to pay call coverage for and actually what they're contracted for. The challenge with any of that type of data, though, is that it's somewhat tainted in nature in that the physicians have an incentive to report higher amounts or negotiate higher amounts versus what benchmarks may say. So it comes down to really making sure you understand, is the market data I have reasonable data? Is it from one source? Is it from multiple sources? And does it really match my scenario? But another way to think about it is, do you employ any physicians of this specialty already? And if you do, when you negotiate with those physicians for total compensation, did you include any percentage or any amount of call coverage in that for total compensation? Oftentimes when we're looking at total compensation benchmarks and total compensation for employed physicians, some consideration for call coverage was contemplated at the beginning of the contract. For a very burdensome call coverage specialty, sometimes that amount is up to 20% of compensation. So another way to think about it is if you start with a total compensation benchmark or an employed salary that you have for the same physician locally, and you look at what's 20% of that salary and how does that compare to a call coverage rate, does that give you an idea of whether that's reasonable or not? 20% would be at the higher end of what we might expect for call coverage, but maybe 5% is another way to look at it. But looking at different methods outside of benchmarks oftentimes will give you the opportunity to have a little more perspective as to determining whether or not the rate is reasonable. Perhaps one of the trickiest scenarios related to call coverage has to do with advanced practice providers and call coverage compensation. As Lyle mentioned at the beginning of this webinar, we're doing 2 other TTT webinars on APPs. APPs are a hot topic right now. But what's really important for what we wanted to cover today is how do APPs impact call coverage compensation as it is now? Well, the way that you first determine that is you understand the relationship. Are you talking about employed APPs and employed physicians? Or are you talking about independent contractor APPs assisting independent contractor physicians? What are the roles of the APP? Are APPs required in addition to physician services to provide the services. You start off by determining the APP's impact by first understanding the relationship involved. For an employed physician and an employed APP, if the APP is assisting the physician by taking phone calls, following up on patients, assisting with rounding, the employed APP is decreasing the burden on the employed physician in providing call coverage by assuming some of those responsibilities. Alternatively, if it's an independent contractor APP that's employed by an independent contractor physician, the independent contractor is receiving services or being assisted in call coverage by the APP, but the independent contractor physician is also incurring the cost of utilizing that APP to assist with call coverage. So in the independent contractor scenario, you could argue not making any adjustment to the standard call coverage per diem, or in the employed scenario, you could argue that the call coverage per diem may need to be decreased a little because you're also paying for an APP to assist that physician, and the burden thus is smaller. Perhaps the trickiest part when APPs are involved is work RVU credit and collections. Are physicians receiving work RVU credit for only personally performed services, or are the APPs personally performing some services, and adjustments should be made to any work RVUs credited physicians for any bonus purposes? And the same thing for collections. If a physician's receiving collections and the services are performed by an APP, you want to make sure those collections align with the right person and the right cost. And that brings us to our final polling question. As Lyle mentioned, if you'll use your camera and hover over the QR code there, the poll will pop up. If you pay for concurrent call coverage, which is coverage at 2 locations or for 2 specialties on the same day, how much do you typically pay for the second specialty or location? 100% of the normal rate for the second specialty or location, no additional payment. 100% of the normal rate for the, sorry, they moved the order on me. 100%, 75%, or 50% of the normal rate, second location and specialty, or no additional payment. And I'll give you just a few seconds to reply to this one. Really interested to see the results. Very interesting. Probably more often than not, 50% of the second specialty is what we see. Although, like anything with call coverage, we'd also say it depends. We've seen up to 100% of the same rate, and we've seen no additional payment as well. So when you're paying for concurrent call coverage, what are some things you can consider determining how much to pay for the rate? First, is it even feasible? If one center is a trauma center and the other center is not a trauma center, what do your trauma regulations require in terms of response time? If you have a 15-minute response time, is it really feasible that a physician can be at the trauma center and also responding to another location that's 30 minutes away? Does the burden allow for concurrent call coverage to be performed? Is the burden so intense that by adding another specialty or adding another location, it's feasibly not possible or not good for patient safety for one person to provide this coverage? And then how much should you pay? Going back to our theme today, the 3 drivers of call coverage. In concurrent coverage, the key difference here in determining is the physician's already available. Keep that in mind. If you're already providing 24-hour coverage, you can't provide 48-hour coverage in a given day. So when you have 2 physicians, you have 2 physicians that are available, so you see a different rate. But when you bring those down to 1 physician, you typically see some discount because you've already paid for the availability of that physician. The difference then is you're adding additional burden and you're adding additional risk for collections, or perhaps you're adding additional compensation by allowing the physician to earn additional work RV bonuses. It really comes down to understanding the total payment that's being paid or received by the physicians providing call coverage. And that brings us to an end of our presentation today. I'll turn it over to the moderator.
Zach, thank you very much. Thanks to both Lyle and Zach for all this great information. If you still have any questions, their presentation and contact information will be emailed to you along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, call or email us. You can also visit our website at pyapc.com for more details about our specific areas of expertise or to subscribe to receive PYA insights. On behalf of PYA, thanks so much for joining us and have a great rest of your day.